Good morning. I'm Dr. Sathish Kumar, pediatric rheumatologist from Christian Medical College, Vellore. I want to thank the organizers for giving me this opportunity to talk to you and interact with you all. The topic given to me to discuss in this refresher course is the dermatological manifestation of primary vasculitis in children. I will share my screen to start my presentation. Hope I am audible and my slides are in the slideshow mode. For the next 20 minutes, I'm going to talk to you about classification of primary vasculitis in children and what are the dermatological features which you can see in children with primary vasculitis. As you all know that primary vasculitis in children often presents with various clinical manifestations which are slightly different from the adult with vasculitis, especially Kawasaki disease, Kenock-Schwann purpura or IgA vasculitis are not seen in adults, or even if they are seen, they are very rare and their outcome and prognosis are different. So the cutaneous manifestations give an early clue the diagnosis in children with primary vasculitis. So it's all about pattern recognition. Again, remember that primary vasculitis disorders presents with predominant cutaneous manifestation. They also have different visceral involvement, which could be part of the disease. So once you diagnose with cutaneous manifestation, you should also look for evidence of internal organ or other organ involvement. According to Chapel criteria, the primary vasculitis in children are classified into large vessel vasculitis, especially Takayasu arthritis. Giant cell arthritis, which is another large vessel vasculitis seen in adults, is not seen in children. In the medium-sized vasculitis, we have polyarthritis nodosa and Kawasaki disease. In small vessel vasculitis, we have IgA vasculitis, cryoglobulinic vasculitis, and hypocomplementic atrial vasculitis, which are immune complex mediated. And another group of small vessel vasculitis, which are ANCA-associated vasculitis, which are granulomatous with polyangiitis, which previously called vaginous granulomatosis, eosinophilic granulomatosis with polyangiitis, EGPA, previously called Church-Strauss disease, and microscopic polyangiitis. So this classification is mainly for adults with primary vasculitis. So ULR, Press, and Printo has come with the specific criteria, classification criteria for childhood vasculitis. So they classified predominantly, again, depends on the vessel wall involved. So if they are predominantly large vessel vasculitis, it is Takayasu arthritis alone. But if the medium vessel is involved, they divide into polyarthritis nodosa and Kawasaki disease. In the polyarthritis nodosa, you can have child systemic pan and cutaneous pan. Predominantly small vessel, they divided into granulomatous and non-granulomatous. Granulomatous is your vaginous Church-Strauss syndrome, and non-granulomatous are microscopic polyangiitis, IgA vasculitis, isolated cutaneous leukocytoclastic vasculitis, and complementic with atrial vasculitis, and other vasculitis which include Behçet disease, isolated vasculitis of CNS, Cogan syndrome, and vasculitis secondary to infection malignancy, also put under the group of other vasculitis. So I'm going to take you through 5 case scenarios to show the variety of primary vasculitis seen in children, where skin could be a clue towards a diagnosis. So here is the first case. It's a 12-year-old boy who presents multiple red spots on the legs. On review of systems, he has abdominal pain with no blood in stools. He has got joint pains involving knees and ankles without any swelling. His renal and liver function tests were normal. CBC was normal. Urine analysis was negative for any protein or blood. And his stool alcohol blood is also negative. Biopsy was done by the dermatologist, which suggestive of leukocytoclastic vasculitis with IgA deposits in the immunofluorescence. His ultrasound abdomen did not reveal any intussusception. So the diagnosis is IgA vasculitis. So in the classification criteria for IgA vasculitis, the purpura, the classical palpable purpura on the lower limbs, not related to thrombocytopenia, is a mandatory criteria. Plus, they should have any one of the following, like abdominal pain, histopathology showing leukocytoclastic vasculitis. They can have arthritis or arthralgia, and they can have renal involvement in the form of proteinuria and hematuria. So other skin manifestation of IgA vasculitis include They can have swelling of the dorsum of the hand and the scalp. They also sometimes present with bullous lesions, such as bullous HSP. Sometimes children can present with a red and tender scrotum, such as epidermoarchitis. You should remember that the skin lesions in IgA vasculitis does not need any steroids for treatment. Steroids are useful only in significant GA involvement, testicular involvement, or renal involvement. Skin manifestations usually settle with NSAIDs, especially naproxen. When you come to the case scenario 2, here is a 10-year-old boy who presented with multiple red papular lesions on the legs and arms, and a history of recurrent sinusitis. He has got 2 times hematemesis also. So this is a typical nodular lesions over the hands and the legs and seen on the body and the face also. So his CBC was normal. He had renal failure and he had hematuria and proteinuria. So because he has got upper airway, lower airway, and the skin and kidney, he was diagnosed a GPA. So the classification criteria proposed by the ULR or press, they should have at least 3 out of 6 criteria. Like histopathology, you should be able to show the granulomatous inflammation. They should have upper airway involvement in the form of pleural or nasal discharge, recurrent epistaxis. They can have nasal septal perforation leading to saddleness deformity, as shown in the picture. They can have chronic sinus inflammation. They can have subglottic, tracheal, or bronchial stenosis. Pulmonary involvement, you can take X-ray, can show cavities. They can show nodules, and they have fixed infiltrates. ANCA will be positive. Again, they can have renal failure. So they also can present with non-healing ulcers. So think of non-healing ulcers, upper airway and lower airway, as vaginous granulomatosis, or GPA, the latest classification. Case scenario 3. So here is a 4-year-old girl who presented to the emergency department with a history of fever for 1 week duration associated with the rash over the body. On examination, she has got redness of the eyes, enlarged cervical lymph nodes on the anterior and posterior triangle more than 1.5 to 1.5 centimeters. She has got the classical rash, which is seen on the back and the front. She also has swelling, non-pitting swelling of the hands and feet. Her investigation showed leukocytosis with thrombocytosis, mildly raised liver enzymes, and inflammatory markers are very high. So the diagnosis is Kawasaki disease. So the Kawasaki disease criteria is a diagnostic criteria in childhood primary vasculitis. All the others are classification criteria. As you all know, that diagnostic criteria is for diagnosis, classification criteria is mainly for the research purpose. So here the criteria, the fever has to be there for 5 days and plus 4 out of the 5 following. They'll have usually bilateral bulbar conjunctival injection without any exudate. If they have purulent conjunctivitis, it rules out Kawasaki disease. They'll have cervical lymph nodes, usually more than 1.5 centimeters. It is usually unilateral. It can be bilateral. Also, they have the diffuse macular rash. They can have erythema of a multiforme rash. So in Kawasaki disease, you can have any form of rash, including atrial rash. Lip changes, red cracked lips, strawberry tongue, or diffuse erythema of the oropharynx. Extremity changes, as I showed you, they have erythema and edema of palms and soles in the acute phase and periangle desquamation in the subacute phase. Remember that all these features does not need to be occurred concurrently. They can occur anytime during the duration of illness. So in Kawasaki disease is a one disease in primary vasculitis where you have a lot of skin manifestation and mucosal manifestations. So this is a classical non-purulent conjunctivitis, cervical lymphadenopathy more than 1.5 centimeters, the oral cracked lips, and the typical strawberry tongue. This is the peeling issue usually happens at the tip of the fingers and the toes, which is seen in the subacute phase. In India, we also see something called BCG reactivation in the children less than 5 years old due to Kawasaki disease. And we also usually see perianal excoriation in acute phase of the Kawasaki disease. Both the things, BCG reactivation and perianal excoriation, are not part of criteria according to American Heart Association. So when you look into the natural cause of Kawasaki disease, the skin changes, erythema, oral changes, eye changes comes on the acute phase. The desquamation usually comes on the subacute phase, is usually after the 2nd week of illness. Nail changes also already demonstrated in the literature in Kawasaki disease. Case scenario 4. Here is a 5-year-old girl who has come with a history of fever for 4 months, painful nodules of the extremities for the last 3 months, and blackish discoloration of the fingers. You can see here, blackish discoloration of the fourth finger. And he has got significant weight loss also. She has got hypertension, she is pale, she is febrile. So this is a classical diagnosis of polyarthritis nodosa. When you looked into the investigation, she has got neutrophilic leukocytosis, thrombocytosis. She has got raised inflammatory markers. Her liver and renal functions were normal, and nerve conduction study was normal. Chest X-ray and Manto were negative. This is a skin biopsy which is suggestive of septal panniculitis with necrotizing medium vessel vasculitis, suggestive of polyarthritis nodosa. Again, we have a ULR plus classification criteria. So here, the mandatory criteria are histopathology or angiographic abnormality. Angiographic abnormality which shows aneurysm, stenosis, or occlusion of medium vessels, plus one of the following. They can have skin manifestations in the form of livedo reticularis, painful skin nodules, superficial or deep skin infarctions. They can have myalgia, they'll have hypertension, they'll have peripheral neuropathy or mononeuritis multiplex. They can have proteinuria and hematuria. So the polyarthritic livedo reticularis rash, they present with gangrene. They can have non-healing ulcers. They can have subcutaneous nodules. And they also have cutaneous skin infarcts as a form of presentation. As a pediatric rheumatologist, as a pediatrician, it's very important to differentiate between the cutaneous and systemic pan because the treatment is different for both. So in the cutaneous pan, as the name indicates, it's limited to the skin. Sometimes they can have polyneuropathy, arthralgias, and fever also can be associated with cutaneous pan. Systemic pan, as the name indicates, they have a lot of neurological involvement, systemic involvement. Usually, cutaneous pan follows streptococcal infection in children. Is a benign cause, chronic and relapsing can be there in cutaneous pan. Systemic pan is a very severe disease, so we should be very aggressive in treatment. If you don't treat it aggressively, it can be cause fatal in children also. This is my fifth case. So here is a picture of the first picture is a girl with a recurrent painful nodules, which you can see, which was there in the body and the extremities. And the second picture is brother. He also developed livedo reticularis like skin rash and tender subcutaneous nodules. So the biopsy was consistent with medium vessel vasculitis, suggestive of polyarthritis nodosa. But why both the children in the same family has a similar disease, polyarthritis nodosa, at the same time, especially only systemic features, without any systemic features, only cutaneous pan. So we thought of a disease called DADA2 disease. It's a monogenic disorder. It is autosomal recessive disorder in CECR1 or ADA2 gene encoding for ADA2. So any child who presents with early onset stroke, with increased inflammatory markers, with symptoms of skin signs of livedo reticularis, large reticular pattern, nodules or skin ulceration, you think of DADA2 disease. So consanguinity is very important because it's autosomal recessive. Usually they don't respond to conventional treatment with steroids and azathioprine like what we do in polyarthritis nodosa. The treatment of choice is TNF alpha inhibitors. So this is my last case. This is another 3-year-old child who presents with atricarial skin lesions with itching. So he was seen in multiple pediatricians, was given all the types of antihistaminics almost for 2 weeks. It resolves for a little time and comes again because he was referred to us in view of persistent atricarial lesion. And when I went to the history, this child has got fever also. He was having burning sensation than itching. Usually itching is part of, we all know that the classical atricaria due to allergy. Here he's got burning sensations. When I touch the skin, it was warm and it was painful also. They can have response to fever and arthralgias can be there. There will be lack of response to histaminics. So the diagnosis is atricarial vasculitis. The biopsy was consistent with atrial vasculitis. So in the atrial vasculitis, you have to do complements. If the complements are low, they can have severe disease. If the complements are normal, they'll have benign course. Usually they settle with short course of NSAIDs or steroids. We'll settle this atricarial vasculitis. Rarely we have to treat with high dose immunosuppressions. So how do you manage these children? So if they have skin is only like a leukocytoclastic vasculitis, but it is also self-limiting episode, rest and trigger elimination. Antihistaminics can be tried if they have itching. Topical steroids sometimes help only for the cutaneous manifestations. But if it is recurrent, especially if they have recurrent IgA vasculitis involving only the skin, you can try dapsone or colchicine. Glucocorticoids and immunosuppressants, especially azathioprine or mycophenolate, can be used to prevent the recurrence. Suppose if there is a skin vasculitis is part of systemic disease, when you treat the systemic disease with high dose steroids and immunosuppression, the skin manifestation usually disappear. Take home message. So most of the primary vasculitis, except Takayasu arthritis, has got skin manifestation. Very important thing as a clinician is to pattern recognition. The whole of pediatric rheumatology is pattern recognition. If you recognize the pattern, you no need to do further tests to confirm. Mostly blood tests and serological tests are to confirm the diagnosis than for etiology. So if any child presents to your OPD with purpuric rash, especially of the lower limbs or any urticaria, you always think of small vessel vasculitis like Chenopshon purpura. If they have systemic symptoms, you think of ANCA-associated vasculitis, especially when they have upper airway, lower airway, and kidney. When a child presents with nodules, libido reticularis, gangrene, non-healing ulcers, you think of medium vessel vasculitis, especially polyarteritis nodosa, which can be cutaneous or systemic. Kawasaki disease is classically, as I told earlier, fever for 5 days, conjunctivitis, oral changes, lip changes, tongue changes, edema of the peripheries with skin rash, you think of Kawasaki disease. And large vessel vasculitis, usually Takayasu arthritis, presents with either pulseless disease or with hypertension. Usually they don't have rash. Treatment of cutaneous vasculitis is usually symptomatic. You treat the underlying disease, they usually resolve. Most of the cutaneous manifestations respond well to your systemic treatment. Thank you very much for patient listening. I want to thank the organizers once again giving me this opportunity to talk on this pediatric rheumatology symposium conducted by the Pakistan Society of Rheumatology. Thank you very much. Warm greetings from India once again. Thank you.